الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين وخاتم النبيين ورحمة الله للعالمين سيدنا محمد وعلى آله وصحبه أجمعين. اللهم انفعنا بما علمتنا وعلمنا ما ينفعنا. اللهم صل على محمد وعلى آل محمد كما صليت على إبراهيم وعلى آل إبراهيم في العالمين إنك حميد مجيد. Assalamu alaikum wa rahmatullah. How are you, everybody? This is me, Dr. Ibrahim Halawani. Today, I am honored by your existence with me, inshallah, and we should resume our cardiac anesthesia note for adult cardiac surgery. Today, inshallah, we will continue in this chapter. This chapter is a keystone in the cardiac anesthesia, which deals about the anticoagulation or anticoagulant and the coagulation in the cardiac surgery. And the other part is the bleeding, okay, and the correction of bleeding. So, as a cardiac anesthetist, you need to be familiar with this one. And as I mentioned before, we are targeting and discussing the main subjects as a whole, as general. Then we will go maybe next lecture, inshallah, or the one after it, in individual types of operation like valvular surgery or coronary revascularization or hybrid or whatever. Okay. Today, as I just telling you, we'll speak about the anticoagulation and the coagulation, the management in our perspective to the cardiac surgeon. Perioperative titration of anticoagulant and procoagulant medication is critical in cardiac surgery because anticoagulant use is very common in cardiac patients for multiple indications. Like sometimes you have patient who is on antiplatelets medication, aspirin, clopidogrel, okay, if he has coronary artery disease. Some patients came on warfarin or DOACs, direct oral anticoagulants, apixaban, rivaroxaban, if he has valve replacement or he has arrhythmia like a self. This is simply speaking. And those who attend with me, if you remember, in the first one, two lectures, we spoke about these drugs, how you review these drugs in the preoperative assessment. Okay. Today we are seeing these drugs from other perspective, which their impact on your management intraoperative. Okay. Perioperative challenges, some things that are unique to cardiac uh, surgery, bleeding risk, anticoagulant and antiplatelets increase the preoperative coagulopathy and bleeding. Also, during bypass, okay, we are using a strong anticoagulant to prevent clot formation. So these things makes an additional risk factor. Okay, to tackle this problem, we need to understand the hemostasis and how we are monitoring or doing monitoring to this coagulation cascade, and then to be familiar with the anticoagulants that I'm using. So I know where is the enemy, this is your enemy, how your enemy will behave, and how to monitor this enemy. Okay, and here why it's enemy, why it is an enemy, how it's affecting your coagulation. Okay, so who is the enemy? Okay, how he will behave, reversal, onset, mechanism, all this stuff, and why it is the enemy, where it attacks the hemostasis, and how to monitor it, and how to treat it. Okay, and of course, we are anesthetists. I'm not speaking from an internal medicine point of view or cardiology point of view. Here, what I will tell you is focusing upon the drugs and the monitoring and the hemostasis that we anesthetists are using in our practice. Okay. To start, what is the laboratory monitoring we are using in the preoperative coagulation? Basic hemostasis, cell count, okay, hematocrit, platelets count, and if the patient has low hematocrit, means that he's bleeding, صح? Because he's losing hemoglobin. Okay, platelets count. How much his platelets? Plasma based anticoagulation test or coagulation test. الBT والINR usually for vitamin K antagonist like warfarin. Okay, الABTT is mainly for heparin, and the fibrinogen level, okay, is for fibrinogen. I just wanted to go with you to give you. I don't want also to give a lot of data, but يعني bear with me because I wanted to explain for you how we are or how the coagulation and the hemostasis is going. The blood clot is fibrinogen, صح? Is fibrin. يعني there is fibrin threads, and inside these fibrin threads, the platelets. This is the blood clot. Simple? Okay. This fibrinogen come from another material or another protein that it's normal present in the blood. It's called fibrinogen gene. Fibrinogen. This fibrinogen, how it is become fibrinogen? By another factor. This one is dissolved, is dissolved inside the blood. Once it comes to thrombin, okay, this thrombin will cause the fibrinogen to become fibrin. Clear so far? Very simple. Okay, so fibrinogen, it is dissolved in the plasma. This thrombin will come to unit with it or to activate it to be thrombin, to be, sorry, fibrin threads, and the platelets will be inside it. So far, clear? Then this fibrin, it acts on by other factors to have fibrin degradation products اللي هو what we call fibrinolysis. So after the body is happy with this fibrin, it will not stay forever. How the body will destruct it? By fibrinolysis to fibrin degradation products. Simply speaking, I am not saying something advanced. Type. This thrombin, where it comes from? It comes from its brother, which is prothrombin. So this prothrombin becomes thrombin to do all this story. Clear so far? How the prothrombin will be will activate the thrombin? We have what we call the intrinsic pathway and extrinsic pathway, and we have also what they call the new molecular theory of coagulation. I will not go through any of these. I don't want you to to go through this. I just want to keep it as simple as we can. Okay. But the main here is activated factor 10, the last thing, activated factor 10, and what else I want to say? And factor 7, which is calcium, for 5. So these are the main stimulants here. Okay, of all these intrinsic pathways, whatever pathways they are mentioned. Okay, fine. So far, I think this is clear, or at least this preliminary structure of the prothrombin, okay, to be activated by activated factor 10 to be thrombin. Thrombin will affect the fibrinogen to be fibrin. This fibrin will have platelets inside to do FDP, okay, after fibrinolysis. So far, I want you to keep this in your mind. Then later on, we will make it more challenging. Right. Let's go. Just a second. Right. Back to our misery. Now, we were speaking about that I told you that some vitamin K, again, to the hematocrit platelets count. As you see, we set the fibrin threads, and inside it is the platelets. So if the platelets is low, it will not be an effective homeostasis. Okay, BT, INR, and ABTT, they are using the extrinsic and intrinsic pathways, the ones that we are, I just mentioned. One of them is depending on vitamin K, and the other one is with the heparin. Okay, and we will expand our knowledge about these mechanisms later on. And the fibrinogen level, which is the threads itself. If I don't have fibrinogen level, I will not have fibrin, I will not have subluxin. Simply speaking. Right. This laboratory test, is it good? Can I use it inside the OR? Number one, it's time intense. Sometimes you send it to the main laboratory, and you are waiting for 2, 3, 4, 5 hours maybe. How can you manage? It's very fun. Designed for a specific therapy. Most of these data have been tailored or invented not for us in the operative bleeding. It's mainly for the general or the other specialties. Only assist early coagulation phase. They do not measure thrombin burst or final fibrin platelets clot formation. Okay, and they cannot detect fibrinolysis deficiency with platelets function abnormality. Okay, so as you see, what we care, again, I'm focusing on you as anesthetist. What you care about the clot formation. This is the one that will hold the bleeding, صح? It's platelets, function and number. It's a fibrin. And if there is a lot of fibrinolysis, means this is a problem. If there is a little fibrinogen, it's a problem. So your focus is here on this step mainly. Okay, that's why we have invented what we call it BOCUS. What's BOCUS? Or sorry, BOCAT, the point of care testing. The BOCAT advantage, it's faster and the comprehensive evaluation in single test because it's targeted what I am aiming for. Like what? Whole blood INR test is activating ACT, and we will speak about, of course, later. And platelets, it's like a new machine called Platelets War, and the visoelastic test like the Rotem. All of these are giving you information about the clot formation, clot strength, which you need to have it inside the OR to deal with your bleeding or homeostasis inside the OR. Is it clear? As you see, this is a quick comparison. INR, this early coagulation. The first step, all of these are before we reach down to the thrombin, to fibrin clot, to fibrinolysis. All of these are not there. Okay, something like Rotem or Tej, this is more fast and more complete, and it will have a direct, nice impact on your action. But now we need to be familiar with this horrible drug, unfractionated heparin. Okay, if we're speaking about coagulation and we are speaking about coagulopathy, okay, so we need to uh, be very famous with our enemy. It's one of our enemies. Actually, it's an enemy in one stage and it's a friend in one stage. On bypass, it's your friend. Post bypass, it's your enemy. So you need to have a comprehensive knowledge of heparin as, again, as a cardiac anesthetist. I am not a internal medicine doctor or cardiologist. No, I need to be familiar with this so I can treat the patient inside the OR. Right, let's start. Background. Heparin, naturally occurring anticoagulant, glucosaminoGlycan polymer with variable chain length. الدالتون بيبقى من حوالي 3 to 30 كيلو دالتون. Okay. Of course, I can give a whole lecture about this one if we're speaking about pharmacology, but don't care about this one, خالص. Physiologically found in liver and lung. Okay, just if you have it in the MCQs, you will know. Commercially, most of the time you will find it inside the OR, either it's bovine or porcine. Most of the time, the unfractionated heparin preparation come from animal tissues. This is the one you find in the OR. Administration, intravenous, subcutaneous. For us, most of the time we are using intravenous. Okay. And the other thing, the duration of action influenced by the dose, the temperature, liver and function, renal and liver function test. Okay. Fine. Don't bother yourself with all of this. Pharmacodynamic. What we mean by dynamic? Can somebody write for me? Type. I will not waste time. Dynamic and the kinetic. Dynamic, it's D and Y. So it is the effect of the drug on the body. Body and the drug. Okay. It's a highly protein bind and internalization. And this is the one I want you to know. It has a wide inter-patient variability. That's why it requires frequent monitoring. Okay. How it's doing its action. Right. It binds with something called antithrombin 3. From the name, it's antithrombin. So what is the effect of the antithrombin? Is to prevent the thrombin. Very simple. Okay. It will inhibit thrombin, okay, with factor 10, and to lesser extent about all the other things. So, and in higher doses can inhibit thrombin independent of AT via heparin cofactor 2. 1 minute. Come with me. Yes. Here, this is the prothrombin becomes thrombin. Antithrombin, AT, it's a protein in the blood. Okay. What does this one do? If factor 10 is giving one stimulus, this one gives 10 negative in preventing this line. Okay. And heparin is his love. Heparin. So heparin, she will go to the AT and tell him, if you love me, prove it for me. He say, how can I prove it for you? She say, prevent prothrombin from become thrombin. Okay. And by itself, sometimes if you give a lot of heparin or the high dose of heparin, it goes with what we call heparin cofactor, and by itself, it causes this opposing. So again, this is important because it has some clinical thing we will build upon it. Heparin to work in high dose, it will work by itself. In low dose, it will give a very good stimulation for antithrombin, and antithrombin is very powerful inhibitor to prothrombin to be transferred to thrombin. And of course, another factors, but just bear with me, get the whole idea, don't go into small details. So let's go back to our onset of action, usually in 2 minutes. So when you give heparin, wait for 2 minutes until you do a LCT. Again, binds reversal to antithrombin 3. Enhance the AT's inhibition of thrombin وفactor 10 والother factors. طب لو higher concentration, heparin by itself, it will go to block. Pharmacokinetics, non-linear. What I mean by non-linear means that its effect and the saturation is not usually clear like this. Sometimes it's fluctuating. Yani sometimes you give huge dose to raise the ACT to 300, okay, and then you give the almost the same dose to raise it from 300 to 400. Yani you give X dose to reach it from 120 to 300. Then you give the same dose to just raise it from 300 to 400 only. Okay, that's why I wrote it for you and I brought this. It's not linear. So don't imagine that most of the time it's not crystal clear. Cleared by liver, kidney, half-life 30 minutes. Okay, so every 30 minutes, usually we are doing ACT. to make sure that the INR is still high or the ST. Contraindication hit, and this is a huge subject, but we will discuss it later. Heparin-induced thrombocytopenia. In this patient has severe low platelets due to heparin. How can we reverse heparin? By protamine sulfate, and it's a we will speak also about it. Usually, how we are measuring or monitoring, it's by ABTT. ABTT is the basic, is the everything, is the well known. If you want to measure the heparin, okay, is it why I'm telling this and repeating it? Because most of the time when you have MCQ asking you how to measure heparin in general, it's by ABTT. But in cardiac surgery, no, it's sometimes different. Why? But heparin monitoring during cardiac surgery is a little bit different. Why? Because ABTT has limitation. We can use it pre-operative, very nice. Post-operative, very nice. But intraoperative, it's time consuming. It will take very long until you have unreliable with high protein dose. As I told you, it will not be non-linear. So the doses we are using in the OR is very high, so it will not be very accurate and not suitable for OR decision making. You will not lead the patient to be bleeding for 2 3 hours until you get the results. Okay, it's not logic. So we need something else. They have what we call it ACT. What mean by ACT? Most of you know the clotting times, صح? And the clotting time is also prolonged. You put the drop and you keep the needle inside it until you clot formation first is ready. صح? This is an old test, but it's also time consuming. That's why we are adding substance to enhance this clotting time. That's why we call it activated, because we are putting something like kaolin or other materials. This will enhance this clotting time to make it quick, easy, compact, cost effective. Very nice and very rapid. Usually, if the ACT is more than 300 seconds, usually it inhibits the fibrin threads formation في oxygenator, and that's why when we reach 300 and sometimes they say 350, they will start red sucker. It's the machine sucker. Okay, the suction of the machine usually started in 300 or 350. More than 480, it's recommended to ensure full anticoagulation for cardiopulmonary bypass. These numbers are not solid. These numbers have a lot of variability between centers. Okay, and follow your own center protocol. Limitation is non-specific. Anything can increase the clotting time, not only heparin. Poor correlation with heparin dose concentration. This is a lot of debate between the companies. I will not bother you with it. Rotem. Rotem can help us in know the effect of heparin, of course, by Entem and Heptin. How? We will discuss it later, but just make it in your mind that Entem and Heptim, we are using it to normalize the clotting time and the prolonged clotting time and compare both to know if it's the effect due to heparin or not. Factor affecting ACT. Age gender. It alters the baseline coagulation rate. AT3 activity and thrombin. If you have a low AT3, will reduce the heparin effectiveness and affects the ACT. Platelet dysfunction, prolonged ACT. So you might have prolonged ACT and it's a problem because of platelet dysfunction or factor deficiency, not the heparin. Lobus anticoagulant interfere with the test accuracy. heparin characteristic, bioavailability مش عارف ايه affected. Okay, variability in the heparin respond in some patient. Cardiopulmonary bypass, membrane effect, the hemodilution, the temperature, hemolysis, all of these can interfere with ACT. So in summary, ACT is fast but not specific and variable. Rotem can help differentiate the heparin effect from other causes. If you have a prolonged clotting time, ACT is activate activating clotting time. If the clotting time is long, if the ACT is high, could be heparin, could be other things. The routine will help you to know is it heparin or other causes. Target more than 840, as I said, and be aware of physiological and technical factors that affects the ACT file. Actually, يعني for your update now, the relay on ACT is getting less and less because it's non-specific and a lot of factors can affect it. Right. Another subject about the heparin you need to know also is heparin resistance, means to failure to get the target ACT after standard heparin dose. Okay, there is also great inter-institutional variability. Some institutes say it is less than 400 despite 600. Some say 800, some say 1000. Okay, but the idea is when you give the expected dose 400 international unit per kg up to 600 international unit per kg, and you still did not get the 400 seconds ACT, this means that this patient has heparin resistance. Incidence is not high, maybe up to 20% cases. What's the problem with it? You will have delay. Yani, you might also get some clots or something. So that's why. But mainly it's the delay because you cannot go on bypass. If it is not achieved, what you're gonna do? You have to wait to solve this problem. Usually, it's the problem is due to antithrombin AT deficiency. This is the main factor. Sometimes the patient has heparin desensitization or heparin binding proteins that cause inhibition for the heparin, or the patient has HIT. These are the heparin risk factors in low ACT, in low, sorry, antithrombin. Mainly, this is the one we have seeing most of the time. Or if the patient was on chronic heparin therapy, sometimes this preoperative heparin therapy for long time, preoperative, cause the AT in the blood to be consumed, and you receive the patient with a very low AT. That's why heparin will not be very effective with them. Management, what we can do, number one, you just increase the heparin dose. This might go overcome this if there is desensitization or inhibitor effect. Other thing, we can address the AT. Usually, if you have recumbent AT antithrombin, you can give 75 unit per kg. This is nice, but it will increase the risk of bleeding. Or you can get this recombinant, and this one is plasma driven from the blood bank. You can give cryoprecipitate, or the best is to give FFB. Usually give 4 to 3 units FFB. Okay, before and then repeat the ACT. Usually, it will tackle this problem. Or alternative بقى if خلاص it's hit, it's better to go for bivaleridiene. Of course, hit, as I told you, it will be a separate subject, inshallah. Post-operative consideration for the heparin resistance. AT usually full box surgery in day 3 and recover in day 5. And this low can cause re-exploration, neurological events, thromboembolism, decreased survival, increased ICU stay. So it's always better to monitor ACT and suspect resistant early, identify cause. Is it HIT? Is it inhibitors? Is it AT deficiency? Use recombinant if available or consider FFB if you don't have. وانتسيبيت بقى الفول بوست اوبراتيف and monitor anti accordingly. 1 second. Now we will go to Mr. Brotamin. Heparin means Brotamin. What is Brotamin? It's a reversal agent for heparin. Where it comes from? From the sperm or the tests of fish. It's strongly alkaline, has high arginine content. Bind ion. This is the item. ان هو bind ionically to negatively charged heparin and form inactive precipitate. So this is the heparin. Okay, it's negatively charged. The protamine came and it's positive, and this complex ion complex is precipitate. An onset 1 to 2 minutes, acts for 30 minutes almost. And a rule of thumb 1 milli of protamine, 10 milligram, neutralized 1 milli of heparin, 100 units. 1 to 1 ratio for clinical reversal. Metabolism, plasma enzymes, excretion unit. Another item I want you to be familiar with, they call it heparin or rebound heparin. Mechanism: protamine get metabolized, heparin released from a complex, and delayed anticoagulant. You know, heparin, as you see, he's having fun sometimes with the AT. Now he's having fun with the protamine and is not paying attention to be an anticoagulant. Then protamine get metabolized, and the heparin find himself alone again, so he will go to do his anticoagulant effect. So what will happen? Bleeding, allergy. Ah, this is the side effects not for heparin, for the protamine. Bleeding, allergic reaction, thrombocytopenia, hypotension, altered protein binding, and increased antithrombin level. All of these are doing also. For whenever we are speaking about protamine, we must speak about, and if it is a nice drug and everything is pink and everybody's happy and the flowers everywhere, it's not the case. Protamine has a serious reaction because it has fish, people who has fish allergy, and this protamine came from uh, fish, so it can cause allergy in this patient. Or if the patient has previous protamine exposure, or patient on NPH, this type of insulin, or men who has a history of vasectomy. Okay. Usually we have three types of reaction. One is histamine released, systemic hypotension, and especially due to rapid administration. Okay, immediate. This is once you give the protamine, you'll find the pressure will drop. They prevent by slow administration over 10 minutes. Usually, my protocol is to dilute it in 60 ml and give it over 10 minutes, especially even in peripheral line. Tamam? This is not. The other one of type 2 is anaphylactic or anaphylactoid reaction. What you will see: hypotension, bronchospas, flushing, edema, immediate or delayed. Immediate after less than 10 minutes, or delayed after more than 20 minutes. Require emergency management. And sometimes it's a very problematic, this one. Type 2, type 3 بقى. This is our awful one. Catastrophic pulmonary vasoconstriction. This one, just some histamine get released. Okay, so give it slowly. This one is anaphylactic. Okay, bronchospasm, flushing, hypotension, edema, all this. But this one is type 3 is pulmonary vasoconstriction. What you're gonna see, you will see RV failure. You will see RV ballooning. Okay, you will see RV ballooning. RV pressure is dropping. RV is getting lower. Usually, you will go direct on bypass. Yani try to avoid the arrest or to give huge doses of vasopressor. Okay. And if the patient develops this type 3, it's better to avoid the pulmonary circulation. Sometimes you give it in the left atrium or the aorta. You ask the surgeon to aspirate it in a clean syringe, and he will inject it inside the aorta direct. Of course, this because this one type 3 is catastrophic. طيب, how can we monitor the مش reaction بقى, can we monitor the reversal of the protamine? Usually by ACT. Target ACT within 10% of the baseline. Okay, fine. So protamine is a key reversal for heparin. Careful administration prevents severe reaction. ACT monitoring. Okay, ensure effective and safe reversal. Know the risk profile. 5. and the management protocol. Then protamine dosing and monitoring. As we see, we said target 10% of baseline and overdose. This is برضه something very important we want to discuss. They call it vitamin P. Most of the surgeon believe is the more you give protamine, the more the coagulation become better. And this is not true because we have what we call overdose risks. If you give more than 1.5 per kg for everyone, يعني we said we will give 10 milligram for every 100 unit heparin. This is 1 to 1. If you increase it more than 1.5 to 1, okay, this to this, protamine will be anticoagulant, okay, and it will increase the ACT, okay. Uh, so it's a better, and this is as I told you how we can confirm it by the intent. Optimal dose, it's better to start with low dose, zero point 0.7 or zero point 0.8, okay, for the ratio, and then repeat. Whenever you find there is still bleeding or the ST is still not normal, you can go slightly higher. But don't go from the beginning with 1 to 1. It's better to start with zero point 0.8. Okay, important dosing. This is something else I want you to be familiar with. Usually, you are giving the first dose of usually we are giving جزاك الله خير دكتور. We are giving the first dose of heparin, the ones that reach the ACT. Okay, يعني for example, now you give your dose يعني 35,000 heparin. Okay, so then after this, the perfusionist give 5,000 on the priming, and then every half an hour is giving 15,000 again, and then he gives 10,000. Then he did not get. Which one you should give the reversal for? Usually, we are giving for the first dose. Why? All of these doses are top up doses. They are replace the metabolized heparin. Does not need reversal. So if this is the heparin level inside the body, here this is the level you start with. Then when the heparin goes down, okay, then your perfusion is to give a new dose to raise it to the baseline. Then it goes more down here, raise it to the baseline, give it more. So the last thing you have here is usually the baseline you start with. And all this metabolized usually given is the part given by the additional heparin by the perfusion. When to give additional protamine, as I told you, and it's better not to give, despite whenever you reach 1.5, it's better not to go anywhere. And as I told you, it's better to consider a routine. Now, okay. Now we will go to other things, which is bleeding inside the OR. The first thing we spoke about is the hemostasis, is the anticoagulates we are using, how we reverse it, how the coagulation cascade is going. All of these are theoretical, as I told you. Now you have a patient, and this patient will have coagulopathy. This coagulopathy will cause bleeding, and so you need to manage this bleeding by giving blood and by correct the coagulopathy. Some goals we're speaking about that we have high transfusion rates in cardiac surgery. Okay, usually to help to tackle this problem, it's better to manage the preoperative anemia, so the patient will have a good baseline hemoglobin. If he lost a lot, if he lost some, you will not need to compensate. Correct the coagulopathy, prevent large volume for the transfusion. Now, this is what we can say a trend. The trend now is the transfusion is to try to keep it as minimal as you can. Why? We will see now. Like, why is there bleeding in cardiac surgery? As you know, surgical anatomical, you are opening the heart. It's the most bloody organ in the whole, yani blood containing, not bloody. I'm not insulting the heart. And the coagulopathy of the bypass, and patient already on medication, and also you are giving heparin. All of this will cause that the problem might be severe. So, what we know for sure that cardiac surgery possesses high risk of bleeding. Cardiopulmonary bypass can cause coagulopathy through a lot of things. If you remember, as we said in the cardiopulmonary bypass lecture, hemodilution, platelet dysfunction, clotting factor, all of this. Preoperative anemia is also need to be managed. Both guided transfusion ensure precise and effective correction. Don't use it haphazardly. And over transfusion is harmful. Okay, even if done with good intentions. Okay, management lies. As bleeding is common, as we said, and critical, a clear understanding of management options is crucial for cardiac anesthesiologists. Broadly speaking, management consists of two main categories: prophylactic and active management. Also, active management has two main pillars: resuscitation and correction. Prophylactic management aims to decrease the chances of bleeding and the need for transfusion, while active management of bleeding means to stabilize the patient condition and simultaneously identify the problem and solve it. Okay? What is the prophylactic policies we are using? Preoperative. Try to assess if the patient anemia. Why you are keeping anemia? If the patient go with you with hemoglobin of 9, for example, okay? If this patient bleeds just slightly, you will find his hemoglobin to be 7. But if you correct this 9 and the patient came with you with hemoglobin baseline 13 or 15, if he bleeds a little, he might end with 11 or 10. At this point, you don't need. What you did is you just improved his baseline by giving something like iron supplementation, folate, B12, erythropoietin, whatever. Yeah, just make sure that try to correct the anemia because it will have sorry a good impact in your management. Also, medication, as we said in the lecture of the preoperative assessment, warfarin, keep to hold it, antiplatelets, Zadoax, everything as we said before. All of these also, instead of taking the patient inside with coagulopathy because of these drugs, at least stop these drugs and let his coagulopathy to be solved a little before going inside. Also, team communication planning is very important. Discuss the risk with everybody. Okay, secure adequate venous line, confirm an A line. You should برضه ready to transfuse by warmer, rapid infusion, cell saver, warming device for the patient and for the fluid. In high risk, you might need hemodynamic support. Keep the blood and the products inside with you. Okay, keeps everything in your hand around you. And also some things you need to use for the perfusion. What? Perfusion also, if you can use the Society of Cardiac Anesthesia in America, they said if you can use many circuits, will be nice. And retrograde autologous priming, the RAB, we spoke about it in the perfusion or the cardiopulmonary bypass lectures. Ultrafiltration is, I will also explain for you in a minute. You know, we have priming volume, usually it's crystalloid, and then we mix it with the blood of the patient. Okay, this would cause hemodilution. With this hemodilution, you will find that hemoglobin will be dropped. But because this patient has a lot of crystalloid now inside his body, So either you can correct this one by giving back you can correct the hemoglobin by giving back the RBCs, or it's simpler to try to remove the excessive crystalloid by doing ultrafiltration. So ultrafiltration will help you to remove excessive crystalloid and keep the hemoglobin slightly high. And also blood scavenging, what we call it, cell saver. Also, it's nice to be used. Some centers are using get the what is remaining inside the uh, reservoir of the cardiopulmonary bypass after the patient is off pump, and you transfuse all the blood. Then some blood will be remaining inside the reservoir. You will ask the perfusionist to put it inside the cell saver to extract all the blood that remain, and they give you. Then you transfuse it to the patient. All of these are trying to do your best to decrease the loss. Also, antifibrinolytic is the purpose to mitigate hyperfibrinolysis in cardiac surgery. You don't want fibrinolysis. Historical drugs there was الابروتونين. يعني it's less effective, limited safety, but some centers are using it. But the standard is using tranexamic acid, inhibit conversion of plasminogen to plasmin, and stabilize clot formation. What does this mean? Let's go to our this one. Here in this step to do fibrinolysis is done by another victim, which is plasminogen, to be transferred to plasmin. And this plasmin is the one who enhancing this fibrinolysis. So if I block this, no, not block, it's doing this. If I block it, I will help the fibrin clot to be stable. Okay, so I am prevent this fibrinolysis to keep the fibrin solid and firm. That's why we are call it. Why you are not? Yes. So again, it inhibits the conversion of plasminogen to plasmin, and this the plasmin is the one that converting fibrinogen to fibrin degradation uh, products. So when there is no plasmin, there is no fibrinolysis and stabilization of the fibrin. Effect. This is meta-analysis finding. Don't bother yourself. The problem here is it has a seizure effect. Okay, with tranexamic acid. They said that there is certain regimen or certain levels of this tranexamic acid. At certain level or 80, for example, it will give you an excellent antifibrinolysis effect. But at 100, it will cause seizures. So see, now all the debate and all the papers you will see in the publication now is try to target which is the safe limit that will cause the highest effective anti-fibrinolysis, and on the other hand will have minimal effect on seizures. Okay, and a lot of debate now whether should we go to low range or low dose or high dose, but I'm just mentioning it for you. This usually the low regimen or the low dose is to go from 10 milligram per kg at induction and then infuse 1 milligram per kg per hour until closure. High will reduce the bleeding more effectively, excellent, but has higher seizure rate, especially in renal function and especially in pediatrics. Okay, in the practice, you can tailor the dose according to risk of bleeding and renal function. Most patients receive a bolus 25 to 50 prior to the cardiopulmonary bypass. You can use or don't use the infusion. As I told you, your level is 100. This one is excellent for anti-fibrinolytic, but it has some issues regarding safety. Here, as you see, this protocol from one hospital that said how much you should give according to the glomerular filtration rate. Okay, if it is simple, you just give a single bolus, 50 per kg, and that's more than enough. And if it's complex surgery, okay, you start by loading 25 and 16 per kg, okay, and the 2 milligram per kg on the bypass, on the prime. Usually, even this is the one we are following in our hospital. As I told you, what else can the perfusionist do with me? We said he can do cell salvage, indication, elective surgery, or even emergency when you expect you will have a high bleeding and unexpected bleeding after heparin reversal. You did heparin reversal and you are off bypass and patients start to bleed. It's better to use the cell saver. Relative contraindication يعني malignancy بقى bacterial contamination all this stuff. Benefits safe, effective in adult cardiac surgery and reduce allogenic transfusion by 33%. So don't underestimate this thing. And of course, we said about whole blood resuscitation. You remove the patient blood group by was, decrease the transfusion by RAM. We have just mentioned all of this. Right. Now, I tried my best. I did all the precautions to try to minimize the bleeding, but bleeding happened. What should I do? Lethal triading bleeding, hypothermia, coagulopathy, acidosis. All of this means the patient is going to into the tornado. He will. You have to break this cycle. Volume status and perfusion and transfusion. Volume status, CVB, pressure variation, stroke volume variation, VA pressure by TE. Make sure if he's bleeding, he needs volume or he's okay. And then you see if he's perfusing well by urine output, base access, lactate, central venous oxygenation, cerebral oximetry. I think we have mentioned these once or twice, or this is the fifth time maybe we are mentioning it. Massive transfusion. If you are giving a lot of backed RBCs, it's better to give for every backed RBCs, give one plasma and one platelets. We will speak to them. Right. So now patient is bleeding, you need to monitor and resuscitate, and then you need to identify the problem. Alas, I am patient is stable now. What's the problem? What should I give? Usually I called it the Power Rangers. Luckily enough, we don't have a lot of things to fight through. Just we have either a heparin effect still there, or the patient has a problem with his coagulation factors, or the patient has a problem with his fibrinogen alone, or the patient has a problem with platelets, or the patient has a problem with who want to write. Somebody write something, yeah, anything. What else? What's remaining here? Huh? Hello, anybody awake? What's the problems that can cause these problems? Surgical bleeding? No, no, no. Surgical bleeding is not for me to correct. Yeah, for God's sake, why pushing to the surgeon? No, in our side. RBCs, he has problems? No, not RBCs. No. I just said fibrinolysis. صح. So, what? These are the five things usually for you to treat as a cardiac anesthetist If the patient has a bleeding, it's mostly يعني medical bleeding. Okay, and that's why both point of care testing is very important. It will help you to identify each one of these because every one of this will have a different scenario in the he wrote here the five: heparin, platelets, fibrinogen, clotting factor, fibrinolysis. That's all. So usually you are going off by bus. Just prepare yourself after the rewarming. Do rotem, okay, or tej, or whatever you are doing, and then it will give you an idea about where is the problem and what you want to tackle. Okay, as I told you, these things or the tej and the rotem usually will give you an idea about all these things, but apart from the platelets. Okay, that's why now they have a specific platelets function test like the BFA 100 or the multiplan and the platelet works. I just mentioned it for you here, and inshallah I will leave the PDF file for you, just for you to know. Now, the point of care we are using is either Rotem or Tej, but Rotem and Tej will help you with all the fives, but their يعني judgment upon platelets is not excellent. That's why you will find that a new point of care is platelets function testing. Okay, so now patient has bleeding, and you wanted to know what's the problem, you will go for TISH, you will go for rhythm, it will give you an idea. Okay, and as I told you, the protomer reversal. Okay, fine. How we will manage. طيب خلاص, I know that the problem is fibrinogen, or the problem is tranexamin, or the problem is platelets. So you also need to understand how to correct. So now you have a bleeding, you did the rotem, you did the ACT, you did the platelets assay, and you targeted what's the problem. So you will resuscitate, you will give back the RBCs. You will correct the coagulopathy by blood products and pharmacology. Fine. Let's get familiar with what is backed RBCs and when to give it. Backed RBCs derived by centrifusion or apheresis, okay? And when to give is usually what we are speaking about. And as I told you, there is a trend now to do what we call it restrictive hemoglobin threshold, okay, by the AABB or American Association of Blood Bank. What is RBCs? When you have RBCs unit in your hand, his hematocrit is from 55 to 65%. And its content of plasma usually 20 to 100 mil. And the volume is almost 350. Okay, hemoglobin per unit is 50 to 80 grams, and it has 250 milligram of iron. And when you give 1 unit, usually it's increases the hematocrit by 3 and the hemoglobin by 1. Okay, so this is the bagged RBCs, the bag, the unit you have in your hand. So when to give, as I told you, a lot of things. If he's young and healthy, keep it less than 6. If he's critically ill, less than 7. Patient with cardiovascular disease, which is all our patients, keep it around 8. If patient has a comorbidity, bleeding, ischemia, symptoms, whatever, keep it at 10. So as you see, the ranges are wide. And so far, I bought it for you here. I will also leave it for you to read about all these things about the threshold. When to do this threshold, which is the best? Is it 10? For my practice, I keep it around the 10, 9 to 10. I never go less than 9. Okay. And I believe this is a little bit safe. Now, another point is, should you give a lot of points here, but I will leave it for you to read later on. But I just want to highlight something. Sometimes you have an old or fresh backed RBCs. Is it different? يعني clinically randomized ratio, no difference in the outcome for short or long RBC storage. Okay, fine. For this storage also, I need you to memorize it because sometimes you will have it in the MCQ. RBCs up to 40 days, platelets at room temperature for 5 days, cryo plasma, it's frozen for 1 year. Another thing is that this prob or proper trial. This is very important. It's done in the military side. If you give one backed RBCs, it's better to give with it one platelets and one plasma. Okay, they call it early and balanced use of FFB. So when you are giving backed RBCs as a resuscitation, okay, give platelets with it and give FFB with it. Okay. This is all. Now we have a bleeding. We are resuscitating by giving the backed RBCs. We know what is the RBCs and we give it to keep our hemoglobin within the safe area. The other thing is platelets. 99.9%. It's the most common problem in the all anticoagulants you are facing is the platelets due to cardiopulmonary bypass, platelets, antiplatelets, and bypass is almost in every patient you are seeing in the cardiac surgery. Okay, transfusion threshold, usually we keep it 1000, and Rotem will help you, but not as I told you 100%. Okay, risk, yeah, you have the same bacterial sepsis, mortality, trally, all this nonsense. Okay, now they are trying to decrease this risk by pathogen reduced platelets and all this stuff. Again, when you have a unit of platelets in your hand, what it is? We have two types of platelets, whole blood platelets and apheresis platelets. This one, as you see, the volume of plasma in the whole blood is less and the platelets is high. 1 unit per 10 kg weight, which is usually we are giving 6 units in other, will raise the count by 30,000. Transfusion threshold, most of the time, as I told you, we are following the 1,000. Again, platelets, high risk, high cost, primary risk, bacterial sepsis from room temperature storage. Pathogen reduction mitigates the risk but increase the cost. This is the ones they are following since 2021. What about the plasma? What is FFB? It's fresh frozen plasma at minus 18 after within 8 hours of collection. Another thing is FB24. Just in case you saw it somewhere, FB24 is plasma separated from whole blood and frozen within 24 hours, not 8 hours. As opposed to rich fresh frozen plasma, which is frozen within 8 hours. It stores the same size, the same temperature, minus 18 or colder, typically up to 1 year. Okay, why? As you see, sometimes you may delay. The fresh frozen should be within 8 hours, but now they said keep it for 24 hours, but they wrote on it. Okay, طيب the volume of the bag you have is 25 to 30. Storage most sow 1 to 6 up to 5 days. Contain all coagulation factors. Okay, and need ABO compatibility but not cross match. Usually we give 10 to 20 milli per kg in massive transfusion, as I told you, 111, or multiple factor deficiency, severe warfarin problem, guided by BT, ABTT, and assay طبعا for each factor. Prophylactic, this is a key point. You don't give it as prophylactic, but sometimes we are give it as prophylactic. Anyway, INR is designed for warfarin monitoring, not for giving FFB, but we are giving it. Anyway, yeah. Alternative, we have what we call 4-BCC, or sometimes they can call it Octa Plus, as I can remember. It replacing the, it has a smaller volume, but has the same factors, the important factors. And it helps you if patient is in only transplant or failure, stuff like this. FFB is used without confirmation through coagulopathy is not اللي هو ايه prophylactic, it's better to confirm with lab or routine before administration. Cryo and the method. What is cryo? It's derived from FFB. It's sold at minus from 1 to 6 for 24 hours. It contains high molecular weight insoluble proteins frozen at minus 18 for 1 year. The bag is almost 15 mils as usual. Typically, it will give you 5 to 10 units. Pooled unit. Mainly, it has fibrinogen, Volvel brand, factor 7, sorry, factor 8, and factor 13. Okay, one bowl, layer 5 bags, will raise it by 50, and the 10 bowls raise it by 7. Indication if you have fibrinogen less than 15 to 20. Okay, by stage or by maximum amplitude or 15 بقى I will write it for you the 15 less than 9 اللي هي ال A5 is the 15 less than 9. We need it to be 15 in يعني complex surgery and 12 as a standard. I will show it for you. As for the FFB, if you don't have FFB, usually you go for Octablast or for Vectors. Also, we have fibrinogen concentrate. It can be also used if you don't have fibrinogen. And as I told you, there is the proper trial. It's 111. So it's prepared from one unit. The unit you have, usually frozen within 1 hour. And yeah, they melt the FFB to degree of 1 to 6. They took the cryo and they're refrozing it again within 1 hour. And the volume is 15 mils almost. Fibrinogen content more than 150, factor 8 and factor 5. I'm sorry for copying. 5 units will raise it by 50. Indication if fibrinogen less than 150. What else we can give in coagulopathy? Now you did the rotim, you did the platelets assay. Rotim tells you he need FFB, you give FFB. Rotim tells you he need cryo, you give cryo. You don't have cryo, you give fibrinogen concentrate. You don't have FFB, you can give Octablood or for BCC. Okay. Then no, it said it's a heparin, so you can give protamine. Or it said it's a fibrinolysis. The problem with the lysis is too much. You can give tranexamic acid. Okay, all of these are no. Then we have some additional, like this desmopressin. Sometimes we give it in some renal patients, in selected patients. It sometimes helps. Usually give 0.3 mic per kg slowly, and we can repeat after 12 hours. Usually you are giving it not in the OR, usually in the ICU. Also calcium chloride you can give it, can help, especially if the patient receive a lot of backed RBCs. And factor 7, recombinant or novo 7, indicated only for intractable bleeding after correction or coagulopathy. Always consult the attending surgery before use it, okay? Dosing, 40 mic per kg, maximum 90 mic. Usually we go for the 90 mic directly, sometimes. Lower doses may be equally effective with lower thromb risk. And if you go with 40, okay, it will be good and it can help you with the coagulopathy and low thrombosis risk, because the warning it has thrombosis risk, and avoid using it simultaneously with BCC or Octablast. Infuse via dedicated IV line only. Dedicated IV line only. Criteria for use: if you have, as I told you, severe bleeding despite correction, everything, and surgeon say no problem, temperature is good, pH is good, fibrinogen is good, platelets are good, INR is good, everything is good. Rotem saying I am happy, platelets say I'm perfect, everything is خلاص. Temperature, pH is good. As I told you, hypothermia and acidosis, the first thing to be corrected. But if the patient has hypersensitivity or ongoing ST changes, or a patient with thromboembolism, severe carotid stenosis, active malignancy, pregnancy, all of these, they should not have factor 7 or novo 7. Okay, that's all. I know it's been a long one. جزاكم الله خيرا. و see you next time إن شاء الله. and السلام عليكم ورحمة الله وبركاته.